welcome back, beautiful people. You're listening to Ewaraba Speaks. I am your host, Ewaraba, and I am so glad you're here today. Now, before we dive in, I want to say a quick Akwaba. Welcome to every new listener tuning in for the first time. Today's conversation is one that is long overdue and, honestly, a little personal for a lot of us. We are talking about dysmenorrhea, which is just the medical term for painful periods. And I know, some of you are already nodding. Maybe you've been dealing with this since your very first cycle. Maybe you've been told it's normal. Maybe you've been given a painkiller and sent home without a single explanation. Today, we change that. By the end of this episode, you're going to understand what dysmenorrhea actually is and why it happens, understanding the differences, recognizing the red flags, and knowing the evidence-based help available are crucial steps. Let's start from the very beginning. Dysmenorrhea is defined as painful menstrual cramps that occur just before or during a woman's period. It is one of the most common gynecological complaints worldwide, affecting millions of women every year. So if you've ever been curled up in bed with a heating pad wondering why is your body doing this to you, you are absolutely not alone. And more importantly, your pain is real.
Now, dysmenorrhea comes in two forms, and the distinction matters enormously.
The first is primary dysmenorrhea. This is the most common type. It's period pain that is not caused by any underlying medical condition.
Primary dysmenorrhea starts 1 to 2 days before your period and lasts 2 to 3 days. It usually begins within the first few years after your first menstrual cycle, what we call menarche. Here's what happens. When your period begins, your body releases chemicals called prostaglandins, and they cause the uterus to contract so it can shed its lining. Totally normal. The second type is secondary dysmenorrhea. This one is trickier, and it deserves your full attention. Secondary dysmenorrhea is period pain caused by an underlying condition affecting the reproductive organs. The pain often starts earlier in the menstrual cycle, lasts longer, and tends to get worse over time rather than better. Some of the most common culprits: endometriosis, where tissue similar to the uterine lining grows outside the uterus. The next is uterine fibroids, non-cancerous growths in or around the uterus that can make periods heavier and more painful.
Next, we have adenomyosis, where the uterine lining grows into the muscular wall of the uterus itself. Pelvic inflammatory disease is an infection of the reproductive organs, often caused by sexually transmitted bacteria. It is also another serious cause to consider. Next, ovarian cysts. Fluid-filled sacs on the ovaries that can cause significant pelvic pain. The important message here is this: not all period pain is the same, and severe pain should never just be tolerated in silence. Go see a healthcare provider if your period pain is so severe it interferes with your daily life, work, school, relationships. Over-the-counter painkillers aren't giving you relief. Your pain is getting worse over time, not better. You have unusually heavy bleeding alongside the pain. You have pain outside of your period. These could be signs of secondary dysmenorrhea, and early diagnosis genuinely changes outcomes. Please don't wait until you're in crisis. Now let's talk about management, because knowing what's wrong is only useful if we talk about what to do about it. You can use heat therapy. It helps relieve the pain by relaxing the uterine muscle. Next is exercise and movement. I know it sounds counterintuitive when you're in pain, but regular aerobic exercise can reduce prostaglandin levels and improve your pain threshold over time. Next, NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen or naproxen. These work by directly reducing prostaglandin production. They are most effective when started 1 to 2 days before your period begins, rather than waiting for the pain to peak. Talk to your pharmacist or doctor about the right dose for you. Also, there's hormonal contraceptives, including combined oral contraceptive pills, patches, or hormonal IUD. These work by reducing the thickness of the uterine lining and lowering prostaglandin levels. Not everyone wants to use hormonal options, and that's valid, but for those who do, the evidence is strong. For secondary dysmenorrhea, management depends entirely on the underlying cause, so that's a conversation for you and your gynecologist. Before I let you go today, I want to leave you with this. You deserve care, you deserve answers, and you deserve a healthcare provider who takes your symptoms seriously. This has been Ewaraba Speaks. I'm Ewaraba, your host, and I'll catch you in the next episode.